Hello everyone. Today I'm going to present the second obstetrics case, which is a case study on missed miscarriage, also known as delayed miscarriage or early fetal demise. So there are two types of miscarriages normally seen in pregnant women. The first is called complete miscarriage and the second is incomplete miscarriage. If the fetus size is small and if the miscarriage occurs in the early stages of pregnancy, especially in the first trimester, it is easy for the body to remove the fetus, or the expulsion of fetus is easy and it does not require any management or pharmacological therapy. But in cases of incomplete miscarriage, when the fetus size is large or when it is not easy to expel the fetus out, we need certain surgical management or medical management to remove the miscarried fetus. So in this case, we have an incomplete miscarriage. Let's learn in detail about this case. Our patient is a 30-year-old woman who was referred from a general practitioner. She is 11 weeks and 2 days gestation and has noticed dark spotting and mild period-like pain for the last 4 days. Her last period was 4 months ago, but she has a history of polycystic ovarian syndrome and has an irregular cycle bleeding for 4 to 7 days every 5 to 6 weeks. She had a positive home pregnancy test because she noticed breast tenderness and came for a dating ultrasound scan 4 weeks ago that confirmed a viable single intrauterine pregnancy. And she's gravida 2 and para 0. Her last pregnancy was 9 months ago, which also ended in a complete miscarriage at 7 weeks. There is no other medical or gynecological history of significance. Further examination was performed, and she is apyrexial, that is, she has no fever, with normal heart rate and blood pressure. The abdomen is soft and non tender, so there are no abnormalities found in her abdomen. Her speculum examination shows a small cervical ectropion, but this is not bleeding. So the bleeding was not caused by the cervical ectropion found in the patient. Now, what is a cervical ectropion? It is a harmless appearance of cervical cells from inside the cervical canal that grow outside of the cervix. So these are glandular cells which are usually seen inside the cervical canal. But if it grows outside, it is known as an ectropion and it is usually harmless. The cervix is closed and no blood or abnormal discharge is seen. So sometimes the cervix is closed or it might be open depending on the patient. In early pregnancies, usually the cervix is closed. If it is open, then it is known as an incompetent uterus and it might cause miscarriages. But in this patient, it was closed. Bimanual examination reveals an 8-10 week sized anteverted mobile uterus with no cervical excitation, adnexal masses, or tenderness. An anteverted mobile uterus, it is a normal position seen in approximately 70 to 75% women, and it refers to when the uterus is tilted towards the abdomen in a forward position, and it is a harmless position and it does not interfere with pregnancies. She has no cervical excitation. Cervical excitation is a test which is performed by inserting two fingers in the cervix and it is moved from side to side. If cervical excitation is present, it might be a pelvic pathology case, might be pelvic inflammatory disease or some other condition. But this patient has no cervical excitation, adnexal masses, or tenderness. So other diagnostic tests performed was a transvaginal ultrasound scan report. The uterus contains a gestational sac measuring 49 into 48 into 36 millimeter. So gestational sac is a fluid-filled structure surrounding an embryo during the first few weeks of embryonic development. So its size was seen, and a single fetus of crown rump length 47 millimeter is visible. Fetal heartbeat is absent. So crown rump length is the size of the fetus. In this, we measure the length from the crown till the rump. Rump is the bottom of the fetus and crown is the top part of the fetus. So the length was 47 millimeter, which is usually around 11 weeks. Fetal heartbeat is absent. So fetal heartbeat is usually seen from the time the fetus is of 6 millimeter length. So since this fetus is 47 millimeter, if it was a viable pregnancy, heartbeat would be seen. But as we can see, it is absent, which means the fetus is not alive or it is not developing anymore. The uterus is anteverted, as we have already seen, and both ovaries appear normal with no adnexal masses visible. So the final diagnosis made in this case is of missed miscarriage. The alternative terminology for this condition is delayed miscarriage, silent miscarriage, or early fetal demise. So, this diagnosis was made for two reasons. First, the fetal heartbeat has been seen previously and is no longer visible. The patient had previous scans also, but at that time, the fetal heartbeat was present. But in her most recent scan, the fetal heartbeat is no longer visible. So, we know that it has been miscarried. Second, where the crown rump length exceeds 6 millimeter, a fetal heartbeat should be visible on transvaginal ultrasound in all cases of a viable pregnancy. Since this patient is 47 millimeter and still does not have a heartbeat, so thus the diagnosis could have been made of a missed miscarriage even if the previous scan result was not known. Let's learn more about this condition. So, miscarriage, which is also called spontaneous abortion, is the death and expulsion of an embryo or fetus before it is able to survive independently. In this patient, the expulsion is not seen, but the death of embryo has occurred. So, we can say that this is a miscarriage. The most common symptom of a miscarriage is vaginal bleeding. We saw this in our patient also. She has dark spotting. Risk factors for miscarriage include being an older parent, previous miscarriage, exposure to tobacco smoke, obesity, diabetes, thyroid problems, and drug or alcohol use. About 80% of miscarriages occur in the first 12 weeks of pregnancy, which is the first trimester. Our patient was also in her first trimester. She was around 11 weeks pregnant. Diagnosis of a miscarriage may involve checking to see if the cervix is open or sealed, testing blood levels of human chorionic gonadotrophin and an ultrasound. So, our patient had a sealed cervix, and her ultrasound showed the missed miscarriage or the dead fetus. Prevention is occasionally possible with good prenatal care. Avoiding drugs, alcohol, infectious diseases, and radiation may decrease the risk of miscarriage. So, especially the first trimester, the patient has to take really good care to prevent miscarriages. In cases of an incomplete miscarriage, empty sac, or missed abortion, there are three treatment options: watchful waiting, medical management, and surgical treatment. Medical treatment usually consists of using a misoprostol, which is a prostaglandin analog, alone or in combination with mifepristone pre-treatment. So let's learn in detail about its management and intervention. The women needs to discuss how to proceed. The management of miscarriage is expectant, medical or surgical. Expectant management involves avoids medical intervention and can be managed completely at home. In certain cases, a patient does not require pharmacological treatment. The fetus could be removed from the body naturally. The body might remove it itself if its size is small. So, in expectant, if the fetus is small, we can go for expectant management. It may involve significant pain and bleeding. Unpredictable time frame, miscarriage may even take several weeks. More successful for incomplete miscarriage than for missed miscarriage. Medical management involves oral mifepristone followed 48 hours later by misoprostol intravaginal tablets. So prostaglandin analogs are mainly used to induce contractions in the uterus. So that would help in the removal of the fetus. Surgical evacuation may be indicated if medical management fails. So, surgical management involves the evacuation of retained products of conception, can be arranged within a few days and avoids prolonged follow up, very low rate of failure, small risk of uterine perforation or anesthetic complication. Success rates for missed miscarriage are generally greater for medical or surgical management, whereas expectant management is very successful for incomplete miscarriage. Further investigation into recurrent miscarriage is usually reserved for those with three or more consecutive losses. So, this patient does not have three or more consecutive losses. This is her second loss. So, further investigation is not required. These kind of patients usually have a successful pregnancy. But if she has a third miscarriage, we need to investigate it further and find the cause. That's it for today's session. Thank you.